And I'd like to introduce Jordan Feld, who came over from Toronto, Canada, and he will have the final presentation of this meeting. And there is no final talk without a few in the future, and that's your task today, Jordan.
Great. Well, thank you, Stefan, and thank you, Ira, for the kind invitation, and really for putting on, once again, a fantastic meeting. I've learned a lot in the last couple of days and really have enjoyed being here. And so I'm going to talk today, finishing the conference, thanks to all for staying to the end, about therapies that will be approved as we move beyond today. And so I guess the first question that I thought I would start with is, why do we need future drug development? And then I'll go through DAAs in development and then think about some novel approaches that might come to pass. So of course, with the therapies that we have, one could make the case, and certainly there are some that do make the case, that we don't really need any new therapies. We've already got very good drugs that are now interferon-free, have cure rates above 95%, a single pill a day in many cases, few adverse events, short therapy, few drug interactions, mostly ribavirin-free, and resistance isn't a major problem. So we've really hit most of the things that we would target if we were trying to develop an ideal therapy. And it's important to think about this because this really sets the bar extremely high for new therapies to become relevant and to make it through clinical trials and into clinical practice. But it's also important to remember that we've just talked about some very complicated thoughts in terms of how to manage patients. And you have really world experts debating about the merits of doing one thing or another, which clearly demonstrates that therapy, even right now with these highly effective agents, is not all that simple. And because of this, the concept that we're going to be able to extend therapy and really have the major public health benefits that these therapies could potentially offer is questionable. And you see here the great improvement in terms of SVR, but if we don't treat more people, we're not going to be able to achieve those benefits. And this means that we're going to need to simplify therapy. So I think that's one of the major roles. So would more drugs help improve this? Well, I think they probably would. First of all, competition, we've already seen this happen in the United States particularly, does bring down the prices, and also potentially gives access to some of the slightly less, in quotes, perfect drugs, but drugs that might be more affordable and allow us to be able to treat in resource-limited settings. It also addresses potentially important treatment gaps, which don't necessarily apply to a large percentage of patients, but still in terms of absolute numbers, is a lot of patients that don't fit into our current treatment guidelines. And of course, we just talked about patients that have failed therapy, which is an important group. And then I think a very important point is that we will need to be able to increase our treatment pool, and to do so, we're going to need to simplify therapy. With interferon, patients were running away from us. They're now running towards us, and the challenge of that is that we really don't have the capacity to treat all of the patients in expert tertiary care centers. So if we're going to move out of specialty clinics, and while Professor Zoitzum has been a very strong advocate that hepatologists and infectious disease specialists should still be guiding therapy for hepatitis C, and that's certainly true, we will need to have primary care doctors at least treating some patients, even if initial management decisions are recommended by experts. And to do that, we're going to need to make therapy relatively simple. So if we think about those strategies, if these are the major reasons for development of drugs, let's talk about what's in development. So first I'll talk about what's coming next. I'll talk about a few specific populations, particularly renal disease and genotype 3, which are important treatment gaps and are going to be addressed relatively soon. Then the concept of having therapies of one size fits all and shorter duration, which is at least to some benefit. So the next regimen that will likely be approved is Grisoprevir, a second-generation protease inhibitor, and Elbasvir, a second-generation NS5A inhibitor. And it's important to recognize that these really are truly second-generation molecules. So sometimes the second-wave protease inhibitors, like Cimeprevir, are called second-generation, but they're really much more similar to Telaprevir and Boceprevir because of their resistance profile. Grisoprevir, as Mark talked about, has activity against the 155K variant, which is one of the most common treatment-emergent protease inhibitor variants, and because of that, it really is a second-generation molecule, and I'll show you the data that support that. In addition, Elbasvir is an NS5A inhibitor that has activity against some common NS5A RAVs, and it does have broader genotypic coverage, and this will be combined in a fixed-dose single-tablet regimen. So if we look at the data in treatment-naive patients, this is looking at genotypes 1, genotypes 4, and 6, but most of the patients are genotype 1. And what you see here is in treatment given for 12 weeks, you see that overall 95% of patients achieved SVR, and importantly, this is a regimen where you have a protease inhibitor and an NS5A inhibitor, two classes where you would expect a very low barrier for 1A. And if you compare this to declatosphere and acinaprovir, a similar combination of a PI and an NS5A, that's not recommended in genotype 1A, and even in genotype 1B with 12 weeks doesn't achieve nearly this kind of SVR rate. So this really demonstrates that this is indeed a second generation platform. And you can see that in genotype 1A, 92% of patients achieved SVR, small numbers with genotype 4, but all were cured, and a very small number with genotype 6. And notably, even in the small number of patients with cirrhosis in the trial, 97% achieved SVR, which was actually slightly higher than in the non-cirrhotic population. When you move to the treatment-experienced population, these are patients that had failed PEG-RIBA, and here, as Mark pointed out, the study compared 12 and 16 weeks of therapy. And if you look overall, what you see is that the advantage of extending therapy really reduced virologic failure. So in the patients that got 16 weeks and added ribavirin to the regimen, you can see that the relapse rate actually dropped to none. So the small number of failures were non-virologic failures, and suggesting, as Mark pointed out, that longer therapy and the addition of ribavirin reduced the relapse rate. If you break this down by genotype 1 subtype, you do see that with this regimen, and again, it's important to remember the components of it, that 1B does extremely well, whether with 12 weeks or 16 weeks. You can see that almost all of the patients with 1B achieve SVR, whether ribavirin is included, whether 12 or 16 weeks is given. But in the 1A patients, where there's a lower barrier for both drugs, even these second-generation drugs, you see that in 12 weeks, without ribavirin, the SVR rates start to drift down just a little bit, down to 90%. So if we look at this a little bit more carefully, we start to see that why is this happening? Well, it's to do with the last two talks. It's to do with the emergence of resistant-associated variants. So this is actually from the treatment-naive study, the first study that I showed you, and breaking down the patients that had baseline NS5A RAVs. And you can see in this case, 12% of the genotype 1A patients had NS5A RAVs. And if you look at those patients, you can see that the SVR rate dropped from 99% in those without RAVs to 58% in those with RAVs. And if you break it down further and look at those with high-level RAVs with greater than 5-fold shift in EC50, that drops down to 22%. So quite a significant effect, and not a tiny number of patients at 12% of the total population. And what you see again here, as was discussed in the question period previously, is that in genotype 1B, the presence of these RAVs really has little importance. You can see that of the patients with RAVs, still all but one of them achieved SVR. Now, if we look at the treatment experience study, you see the same pattern, but you see, I think, really highlighting very clearly what Mark outlined, and just shown again here, that if you extend therapy and add ribavirin, you can largely overcome the importance of these baseline RAVs. So again, shown on, if you look at the patients with no baseline RAVs, you can see that 12 weeks, 16 weeks, it doesn't matter. Ribavirin makes no difference. But in the patients who have the baseline RAVs, if you add ribavirin, you see you get a bump, and if you extend therapy, you get a bump, and if you do both things, you actually overcome the problem entirely. And you can see in 16 weeks of therapy with ribavirin, small numbers, but this really overcomes the problem of baseline RAVs. And I really think does make the case for thinking about testing, and I think the biggest resistance to antiviral resistance testing is really coming from hepatologists. And we have to get over this resistance, because here there's clear value in extending therapy, adding ribavirin, and as Mark said, getting it right the first time, but to do that, we have to do the resistance testing before starting therapy. And an important point about this regimen, which again really demonstrates that it is a second-generation regimen, is Mark showed these data already. I'm just highlighting them again in the C-Salvage study, where patients who had failed a PI, cimeprevir, boceprevir, or telaprevir, were given this regimen that contained an NS5A and PI, so maybe something that we would have thought didn't work, although here the in vitro data did actually bear out in the clinic, where you see that the 155K regimen, you can see that this is broken down by patients. So of all patients, 96% 96% achieved SVR, but if you break it down and look at those who had virological failure, most of them achieved SVR. And importantly, even of the 33 patients who had RAVs at the time, to the protease inhibitor at the time that they started therapy, you can see that 31 achieved SVR with this regimen. But you will notice one thing that's important here is ribavirin was included. So I think this speaks to, again, the point that Mark made, that in retreatment, ribavirin is a useful adjunct here, and this regimen looks promising even in PI failures. And then these data were already reviewed by Dr. Martin on Thursday, but looking at the role of this regimen in renal disease, which I think is a very important unmet need. It's certainly common, Hep C is common in the renal population, and we don't really have great options. Sofosbuvir is renally cleared and not recommended for patients with significant renal impairment. And although paritaprevir, ombidisvir, and dasabuvir are all hepatically metabolized and safe, and at least what we've seen look to be reasonably effective in small studies, the data are very limited. So what about this combination in renal patients? You saw this data before, the C-SURFER data, which looked at patients with advanced renal disease, 3/4 of whom were on dialysis. And you can see some other factors about these patients. Over half had genotype 1A, and just under half of these patients were of Black ethnicity. And so if you look at overall, the SVR rate was very impressive in this study at 94%, and you can see that, in fact, there was only one virological failure in this study. Interestingly, it was a genotype 1B patient who had a baseline NS5A RAV and relapsed with RAVs to both agents in the regimen. But so this really demonstrated very clearly that this was a highly effective regimen, and I think perhaps more importantly is the safety, because this is a sick, difficult to treat population, and importantly in this study they did have a placebo comparison, and patients were then rolled over to active treatment. And if you just look at the highlighted bars, you'll see that actually the overall adverse event rate, although high in both groups, was actually slightly higher in the placebo arm of the trial. And if you look at the serious adverse events, again, not statistically different, but certainly not higher in the treatment arm, slightly higher in the placebo arm. So really showing that even in this very sick and difficult to treat population, a very safe regimen. So to summarize on this regimen, which will hopefully be approved early next year, this is an effective second-generation combination of a protease inhibitor and NS5A inhibitor, achieving 95% SVR rates in both treatment-naive and experienced patients, including those with 1A, and that's, I think, a real change for this relatively simple nuke-free combination. There are similar data in patients with cirrhosis. There's an HIV trial that I didn't show, the CKD, and even in PI failures. And the main issue is really the presence of baseline NS5A RAVs in 1A, but longer therapy and the addition of ribavirin overcomes that. But to make these simple modifications, we need to test for it, and I really think we need to start doing that in the clinic when this regimen becomes available. Now, another major gap is genotype 3 with cirrhosis. So when we look at the current regimen, soft-riba for 24 weeks is an expensive regimen that's not very effective in this population with about a 60% SVR rate. Sofosbuvir decladisvir, we were hoping this would be the answer, but really for 12 weeks it's not so effective with a similar SVR rate. And although the EASL guidelines recommend 24 weeks for this population, the truth is that's based on only real-world data with no randomized controlled data to support that. It's very expensive, and we really don't know the efficacy at this point. So clearly a therapeutic gap. So this is an area where we do now have I hope, some promising options. So velpatasvir, which was previously known as GS5816, is a second-generation NS5A inhibitor with, importantly, very strong activity against genotype 3. And this is borne out here in this phase 2 trial in genotype 3 patients without cirrhosis, but patients who had previously failed PEG-RIBA, and you can see that when given at the higher dose of 100 milligrams in combination actually with or without ribavirin, you can see that all of these patients achieved SVR. And then the real test of this regimen is putting it into treatment-experienced cirrhotics, the group that we don't really have a great interferon-free regimen for at this point. And when you look at this combination, again given for 12 weeks, you can see that 25 out of 26 treatment-experienced cirrhotics achieved SVR with 12 weeks of this combination with ribavirin. So although the numbers here are pretty small, it looks like ribavirin still adds an advantage. And one nice thing about this regimen is it is fairly pangenotypic, so it's active beyond genotype 3. Phase 3 trials are now in completion, just being completed, and there's a trial, the Astral 1 trial, in genotypes 1, 4, 1, 4, 5, and 6, and that's looking at 12 weeks versus placebo. The Astral 2 study to compare versus soft-riba. The Astral 3 study to compare versus soft-riba for 24 weeks. And finally, the Astral 4 study with and without ribavirin to look at the efficacy in child's B cirrhotics. So these studies are now either completed, and we're waiting the data that we'll see the first glimpses of the data at AASLD and some of it next year, and this regimen certainly holds promise. Now, this is not the only pan-genotypic regimen in development. There are a number that are in relatively late-stage development. So AbbVie has a combination of a second-generation protease inhibitor and NS5A inhibitor. The reason I put a question mark, still unclear how active this is against genotype 3, but certainly active against all of the other genotypes. Very early data at this point. Achillion has developed sovaprovir, which is a protease inhibitor, and their 3102, the NS5A inhibitor, now has a name and is also combined with their nuke, so triple therapy, which looks fairly promising. Merck, in addition to the combination that I just described, will add a nuke, and they may replace elbasvir, the second-generation NS5A that I just showed, with an alternative agent, 8408, which may be more active in certain subpopulations, particularly genotype 3. And then Gilead, I showed you the regimen with SOF and velpatasvir, and then, as Mark showed you previously, adding a third drug, a protease inhibitor, 9857, or a non-nuke inhibitor, 9779. And all of these are being evaluated in either phase 2 or in phase 2 trials at this point. So I'll just show you a little bit of data on some of these regimens. So here's the Achillion data with their NS5A inhibitor combined with sofosbuvir, so not their own nuke, but with sofosbuvir in treatment-naive genotype 1 non-cirrhotic, so a pretty easy group to treat, but you can see that in this population, short therapy given, so they did an initial trial of 8 weeks, and you can see all 12 patients achieved SVR, and they followed this up by a 6-week trial with just these 2 drugs and 100% achieved SVR. They actually have said that they're planning a 4-week trial and expansion to other populations, and they will likely add either their own protease inhibitor or symeprovir now that they've teamed up with Janssen for further development. However, the 4-week trial is a bit of a question mark because we've all seen these data that were presented first at AASLD and then further data at EASL looking at the combination of the protease inhibitor and NS5A inhibitor that I showed you at the beginning combined with sofosbuvir. So this would be a very potent PI, a very potent NS5A, and the only nuke available right now. And this was looking at 4 or up to 8 weeks of therapy. And unfortunately, even in the treatment-naive non-cirrhotic patients, 4 weeks was clearly not enough. It did look like 6 or 8 weeks was more promising, but only a 33% SVR rate with 4 weeks. And it's not just this combination. If you look at another combination with sofosbuvir and velpatasvir, GS5816, combined with the protease inhibitor 9857, and you can see that again, 4 weeks really not enough. So we see a very low SVR rate with only 4 weeks of therapy. And this really does suggest that with our current approaches, using just very potent DAAs, 4 weeks is very unlikely to be successful. And I think, particularly as Mark pointed out, we want to get this right the first time. So I'm not really sure that we should be doing too many more trials of evaluating 4 weeks once we have these data showing that even in relatively easy-to-cure populations, this doesn't seem to be a very probably effective strategy. So is there another way forward? A, can we get down to 4 weeks? And B, can we think about using things other than direct-acting antivirals? Because of their success, there actually hasn't been a lot of interest in developing host-targeting agents or other things, but I would make the case that there may still be a role for thinking about other approaches other than just adding more DAAs. So most of us are aware that microRNA 122 is an important host factor for HCV replication. The virus microRNA 122 binds to the virus in 2 sites and is necessary for its replication. And based on this, miravirsin, which is an oligo which sequesters microRNA 122, has been effectively used to treat HCV. And you can see in this trial where miravirsin was given in weekly injections, you can see that HCV was suppressed in these patients with chronic infection. And this was, I think, a very important proof of concept that you could inhibit the virus with a host-targeting agent. And although that drug looked promising, it was injectable and maybe not as promising as some others in development. So another microRNA 122, which is now called RG101 at this point, has a little bit better profile because of a GalNAc linkage, which leads to better uptake in hepatocytes and much better microRNA 122 sequestration. And so these data were shown at EASL for the first time, and what you saw is in this trial where patients were given a single injection, you can see that 9 out of 12 patients went on to have undetectable HCV RNA, which is this single injection of a very long-acting drug, and in fact 4 of the patients remained undetectable out to 20 weeks, and there was no further follow-up. So this is an interesting concept, because on the one hand you could say, well, not all patients responded, so maybe DAAs are better than this, and certainly RG101 is unlikely to be a strategy on its own, but as a combination with DAAs, it's very long-acting, so you could potentially shorten therapy to a shorter time. It has a very high barrier to resistance, which might be important in patients who are non-adherent. So you could imagine a strategy where you give an injection of this drug, you give a DAA combination, and then you follow up with a final injection of this drug and lead to a short duration, high chance of SVR. And one other strategy which I'll mention is just the idea of reusing old drugs, which really might be important for bringing down the price. So there are a whole number of host proteins involved in HCV replication. This is just one of the many studies that have looked at the entire list of host factors involved in HCV replication. And Jake Liang's group did an interesting study. After they followed up their original genome-wide study to identify host targets, and one of them that they found was actually an antihistamine. Well, histamine, they found that antihistamines block a post-binding step in the HCV life cycle, and you can see here in primary human hepatocytes and also in humanized mice, the addition of chlorcyclazine, which is a commercially available antihistamine, seemed to suppress the virus quite significantly. And so combining this, certainly this is not going to replace DAAs, but you could imagine a scenario where this was added to DAAs to allow you to have either a shortened therapy or a much cheaper therapy because of the low cost of this regimen. Finally, to summarize, there's still lots of development, and I think that will hopefully lead to continued competition and lower prices. In terms of next step, crisaprevir and elbasvir are clearly the next thing, and their major advantage will be for the renal population. Genotype 3, I hope that sofosbuvir and velpatasvir will be a better answer than things we have today. And then we have lots of pan-genotypic regimens that are in development in phase 2 and phase 3. But I think shortening therapy beyond 6 weeks, and really arguably even beyond 8 weeks for most patients, will take a new approach. I think thinking about host targeting agents is an interesting concept, particularly if we look a little bit more creatively, something like these antihistamines, which could give us a very cheap and effective therapy. And I'll finish with that and be happy to take any questions. Thank you.
Questions from the audience?
Perhaps one question, Jordan, with respect to odalasvir. This is a NS5A inhibitor with an ultra-long half-life. It gives you a little bit of a concern initially because from a pharmacokinetic standpoint, you would consider that this drug would actually need a loading dose. On the other hand, it may have an advantage of acting 4 weeks after the last dose was taken. You think that may contribute to the success of this very small trials with 6 weeks, 100%? Or do you think that's just a by chance finding they had?
I mean, I think it's hard to write it off completely as a chance finding. There are some, I think the pharmacokinetics probably do play a role. So you've got 2 high barrier drugs, one that lasts for a long time. And interestingly, in that trial, they actually did have patients with pretty high baseline viral loads. Now, and some of them had NS5A variants as well. So it does suggest that it really is a second generation NS5A inhibitor with some certainly potential advantages. And it'll be interesting to see when it's combined in harder to cure populations. I guess the question of whether it's worth going to 4 weeks with that, I would really question that as the next step for evaluating that regimen. I would think to try to prove that it's effective in 6 weeks in a broader population with a third drug would be a better approach.
Jordan, I think it's worth reminding the audience that historically you gave a talk at our first Congress in 2012 on the potential future viability of interferon, including new forms of interferon. Also remind the audience that you're one of the major researchers in the world on the mechanism of action of ribavirin. So just harking back, and maybe we should close on this historical note, to Stefan's point at the end of the last talk, is interferon dead, or do you think it has a role? And do you think ribavirin is still going to be around in 3 to 5 years?
All right. Well, unfortunately, I think some of our studies on ribavirin have come to a bit of a halt. It's been very hard to study it further than what was done early on, and I think it's still has an important role. I think what Mark talked about being it's certainly in salvage regimens until it's better understood exactly how it can be replaced. I think it clearly still has a role. I think my take on both of those drugs is they will still have a role in resource-limited places. And I would make the case that interferon will likely have a role in Asia for a very long time. With the very high cure rates in a high IL-28 BCC prevalent population, there's a lot of sense to using interferon, and especially one of the challenges we've seen with hepatitis B and in the early days of HIV was misuse of the drugs led to very difficult to cure populations. One advantage to both interferon and ribavirin is we've all seen patients that were treated with, let's just say, unusual courses or regimens of therapy. At least that doesn't lead to problems if you then retreat them with more effective regimens. So I think they will continue to play a role in resource-limited places. I think the tolerance for them in wealthy nations is diminishing by the day, more from doctors, to be honest, than from patients. So I think within probably 3 to 5 years, we will not use interferon ever, and ribavirin maybe in patients like Mark's example where we really throw the kitchen sink at them, but that's going to be a very small minority of patients. And the only sad thing I would say about that is that ribavirin is a pretty unique antiviral. It does have activity against other viruses, hepatitis E most recently, RSV, and maybe even Ebola. So there might be some value in still studying this drug, but I think for hepatitis C, its days are numbered.